Hi, everyone, and thank you so much for joining us today in our video interview series. Today, we have Dr. Yuli Chettipally. He's a dear friend who's a physician, a speaker, a researcher, and an innovator. I met him at SOPI organization that he founded, and he brings innovation to the clinical space, to clinicians, and sharing that with the world. So we've stayed friends since then. He's been inspiring and amazing. So I'm really excited to have him here. He's very passionate about delivering artificial intelligence enabled solutions at the point of care so that we can improve outcomes and we can co-collaborate. He's the founder and chief technology officer of Crest Networks, which is a multi-centered collaborative research network at Kaiser, and it covers 21 hospitals in North California. So he's done some very interesting things that we'll be talking about. Briefly, what he's done that I found very interesting was that he's designed, developed, and implemented a region wide clinical decision support platform to deliver real time predictive analytics to physicians so they can know and expect what's to happen and be prepared for it. And in fact, he received a Pioneer Award from Kaiser Permanent Innovations for doing that. And recently, Dr. Yuli authored a book called Punish the Machine, which I have here with me. And it's very interesting and fun. Of course, the title itself is really provocative. So we're going to be talking about that and what he outlines in the book about the problems in healthcare and how AI can help. So in addition to all these things that he's done, his other roles include chairman for the Society of Physician Entrepreneurs, for the San Francisco Bay Area chapter, being assistant clinical professor of medicine at University of California, San Francisco, and is the secretary treasurer for San Mateo County Medical Association. So, wow, so much. What a this is amazing, Dr. Yuli. Welcome to our chat here.
Thank you, Sangeeta. I'm really privileged to be on your show. Thank you for having me, and thank you for that great introduction.
Well, thank you. It's you have done very interesting things, and I love the way you think. So let's get started and let's introduce our audience to a bit about your background, kind of how you started your journey in healthcare and where you met technology.
Sure. um, well, I trained in medicine, did my medical school in India, and came here to Los Angeles. I did a research fellowship, an NIH-funded research fellowship in hypertension research. And during that time, I also did a master's in public health at UCLA. After that, I joined a residency program in emergency medicine. And the reason why I chose emergency medicine was that it was a very interesting program in the sense that in emergency medicine, you see all kinds of patients. So anywhere, any age, any gender, any health problem, anything that happens to people, they show up in the emergency. So that was very interesting to me. And I liked the flexibility of the hours and the career. So that's how I started with emergency medicine. And my first job was here at Kaiser Permanente in Northern California. Uh, and that's how I got my career started in emergency medicine. Um, I guess the first third of my career, I was on the administration track. So I was the assistant chief and the chairman of the department. Um, got bored with that and switched to, well, actually, I took a year sabbatical, and did a startup here during the dot-com boom time. Of course, the the startup didn't go anywhere because when the bust happened, we didn't have enough money to continue doing that work. But I went back to Kaiser and I helped start a call center in Pasadena. So that was interesting work, a little bit of operations and how do you create a new workspace, and that was interesting work. But I was
Mhm.
getting tired of the travel, and that's when I started the research network, Crest Research Network. I was the co-founder of that group.
Tell us more about Tell us more about the Crest network. It looks like it was a very early stage where you started to look at this collaborative research and leveraging technology. Which year was that? I think it's almost a couple of
Yeah,
decades ago that you started to think
about
along
about
those lines. So,
about 10 years ago. So what happened was in 2005, around that time, Kaiser Permanente implemented Epic as its electronic health record, and then everybody, every department was now on this EHR, basically paperless. So we have been collecting a lot of data in the EHRs, and that's when myself and another physician, Dr. Dustin Ballard, we got together and started thinking. There's so much data being collected. Uh, I bet that it would be nice to go in and look at what we can learn from that data, and that's how we started the Crest Network. So the idea was to do research on that data that we're collecting in the electronic health record. And once we started doing some studies, we started with some stroke studies, head injury studies, and we found that it was a very interesting way and a very efficient way of looking at things and coming up with some conclusions based on the findings. That's when I got inspired to, maybe we should build a platform to be able to do this research, so that we can collect data from the electronic health record and automate a lot of those processes, collect information from the physicians who are seeing the patients, and also be able to provide feedback to the physicians based on the findings that from our research. And that's how I became the technology lead for the group and started building this.
nice. So, what did you learn from that data? What kind of outcomes, and what was the data indicating in terms of the problems that you're seeing in the system at a large scale, being at Kaiser, as well as what were the outcomes of understanding this data?
Yeah, large scale is definitely true because we see more than 1 million patients coming through the emergency departments every year. So there's definitely a lot of patient information and data that is coming through. So what we did was we picked a few topics to study. Um, for example, we were looking at pulmonary embolism. And number one, what we found was that, of course, the practice was very um, uneven in the sense that there's a lot of variability between one center to the other, one physician's practice to the other. And so first we wanted to study that,
Mm-hmm.
look at the retrospective data and see what we can learn from it. And the second thing we did was we looked at the literature to see, are there any risk stratification tools that will help the physicians practice in a way that will help them make decisions. So can we use risk stratification
Mm-hmm.
tools to help them with clinical decision support? And so
Mm-hmm.
we built this application on the platform. What it does is it'll collect data from the specific patient that the patient and the physician is seeing, and it walks the physician through a few steps and then gives them information about that patient. It analyzes the data and gives the information to the physician. Um, it says that the chances of this person having a bad outcome and gives a number. And based on that number, it will also tell the physician what the next step should be based on this
Mhm.
data. So it is giving that kind of support so that the physician can make the right decisions. One of the things we noticed was that about 95% of these patients were being admitted to the hospital once they were diagnosed with pulmonary embolism. So one thing we know is that a lot of low risk patients, they do just fine. They don't need hospitalization. So we implemented this clinical decision support so that physicians will be comfortable finding those low risk patients so that they can be sent home on outpatient medication. Uh,
Mhm.
in a way, improving the quality of work and improving the patient satisfaction because the patient will be happier at home, and also improving the outcomes for the organization.
Mhm.
That was, and it was a great success.
Okay, that's really cool. I mean, I think that's very interesting. Like you took that data, you're starting to understand what are the needs, what is the data indicating, and then you build this decision support tool to um, uh, help the physician with being able to recommend
Yes,
the appropriate suggestions for it, right?
exactly.
So, what was the impact of this?
Well, so what we did was we implemented this application in 10 medical centers,
Mm-hmm.
and the other 11 medical centers were used as controls.
Mm-hmm.
And we did a clinical trial to see what the effect of this tool would be on our outcomes. Basically, admission rates, return to emergency, and hospitalization rates. And
Mm-hmm.
what we found was that where the tool was available, the outpatient treatment rates doubled. In other
Mm-hmm.
words, whereas in the control sites, it stayed the same. So the tool was actually making an impact on how the physicians were making decisions. So it was actually
Wow.
helping the physicians make decisions. And we also found that 70% of the physicians were actually using the tool, and which is a great thing because sometimes we wonder if we create all these great applications and we wonder if it is actually being used. Um,
Mm-hmm.
so one thing we learned was that if you give physicians something that they can use
Mm-hmm.
and apply it in their practice, and it's not too intrusive, and it fits into the workflow and doesn't take too much time, then they'll use it.
Yeah, that's really interesting because I think in your book you talk about the resistance to AI and the resistance to technology from clinicians. Do you want to touch a little bit on that?
Sure. So in a way, the general thinking is that, oh, physicians don't like to use technology. Of course, if you build crappy technology, they won't like to use it. If they have to spend a ton of time clicking things, then no, they don't like to use it. If the technology is too dumb, no, they don't like to use it. If it is smart, if it is quick, if it is fast, and if it makes sense, it should make sense for the physician to use something. And it should either improve their efficiency or improve the outcomes. If it's doing neither, then probably they won't use it. So that's a, um, a false impression that physicians are averse to using technology. That's very not true. Physicians love technology only if it makes them more efficient or if it makes the outcomes better. And it better be smart, it better be user friendly, and it better be quick, because they don't have too much time to spend. So all our applications, the way we designed was that you know physicians will get an answer in less than 60 seconds.
Mm.
If it cannot do that, then we got to go back to the drawing board and redo the thing until we get that under 60 seconds because we don't want the physicians to spend too much time on this.
I like that, the 60 seconds, being able to give them something of value right away.
Yeah,
And I think what you're highlighting is the need for co-creation and improving user experience, right? So we are not
exactly.
building in silos, you know,
Yeah,
technology experts building technology because they think it will help, but not including healthcare professionals, and same way healthcare professionals trying to build things but haven't really incorporated the right technologies or the right user experience. So I think
yeah.
bringing that together is really important.
Yeah, user experience is very, we take it very seriously. The way we design is that, you don't have to actually go and log into another system.
Hmm.
The way we design this is, you click a button inside of the patient's chart, actually, so that when you click that button, it opens up our application inside of Epic's browser.
Hmm.
So that was the first thing. How do you access the application, right? You don't have to, keep typing user ID, password, and you forget the password. Nothing of that sort. Number two, uh, most of the data is automatically uploaded to the application, so that the data entry part is minimal. So there were, we needed 11 variables for this study uh, to be entered into the application. Out of
Hmm.
these 11, 10 were automatically pulled from the EHR.
Hmm.
Number three, it should not take more than 3 seconds to load. If it's taking a long time and you see this circle going around, we don't want that. So it has to load with under 3 seconds. Number four, it has to fit in with the workflow of the physician. So while they're seeing the patient, it has to fit into that workflow. Number five, not more than 5 lines on a screen. If you're putting too much stuff, physicians don't like to do it. And the other thing is, it has to be self-explanatory, which means that it should not take too long to learn how to use the system. So we set a limit of 5 minutes. Any new user should be able to use the system in looking at it for 5 minutes, and that's all the training. There's no training. But we did educational programs around this application, why they need to use it, because that is important. They need to understand the mission and the purpose behind
Hmm.
this application. That's when you get their mind share, and then physicians will definitely use it and make it happen.
Right. Yeah, you brought up some really good points about, how to make this solution accessible and usable for people. I think a lot of times uh, we may not be thinking as carefully about it, and if we can't improve the usability of the solution, then that of course impacts whether people use it or not. And if people don't use it, you can't you can't make a difference, right?
Yeah,
So I think you've really thought about it a lot.
it's a well thought out program. One of the things that we always think about is, what is the physician getting out of this? And you have to give physicians something back, otherwise, they will not use it. So number one, you know, bringing them on board initially and sharing with them the mission. The mission is
Mhm.
to make the care better, to make
Yeah.
improve the quality of care, improve the outcome. So that's number one. They need to buy into that, or else it won't fly. Number two, you have to decrease their burden. So in this case, we have decreased their cognitive burden, which means that they don't have to think too much. They don't have to go home and worry, oh, maybe I shouldn't have discharged this patient, or maybe, oh no, I did something wrong, or worry about things. So you got to decrease that burden. Number three, what we did was we also once they go through this application, it gives them a full note, a clinical note that they can put it into their documentation, so that they don't have to redo the whole work again. So it'll describe the patient, describe the risks, describe the calculation, the score, and the rationale behind why they did what they did. And so that actually eases some of their workload.
Mm-hmm. Yeah, I think those are, yeah, really good points about how to make it, seamless um, in their workflow and make it useful.
Yeah.
I think you're sharing really good points that will be very helpful for many of the entrepreneurs and as well as other people who are thinking about taking healthcare to the next level. Um, I would be remiss if I didn't bring up interoperability. So, so as you know, that is one of the bane of being able to do a lot of the things you're talking about in terms of being able to have within the login itself, so you don't have separate sign on, right?
Yeah.
Having that a single sign on, being able to pull the data, being able to provide suggestions, and then being able to push the data back. um, that's great, and that's the right way to do the system. But as you know, right now, with all the barriers to being able to access data and to be able to push data, it makes it very difficult for innovation from outside of these large organizations, Kaiser and Epic, um, to really become mainstream. Right, so solutions that patients need, clinicians need, but unless they have interoperability, it will not stick, as you so eloquently laid out. I know
That's
that
true.
there is, right, all this innovation happening with the FHIR APIs, the interoperability, and the new CMS mandate for having open data access to move things in that direction. What are your thoughts about it in terms of the barriers for interoperability and where you are seeing this industry going, and how different people in the industry should be thinking about it?
Yeah, I mean, that's probably a, a big challenge. Eh, and I'm glad that a lot of smart people are working on those barriers, and how to break those barriers. For me, I was lucky that I was inside the organization, and so I was an entrepreneur. And entrepreneurs have other barriers that they have to think about. But definitely, when you're working from outside, you just have to um, find those windows, find those doors, where whether it's APIs or whether it's a app store for that, for that EHR, or other ways to plug into the data. It's a major challenge. I mean, there's no easy solutions. I'm glad that CMS is thinking about it and working on it, and I know a lot of my colleagues are also a part of that um, group that is working on it, and I'm hoping that we will have a solution, or at least some kind of solution very soon, where the EHRs and healthcare companies are mandated to be able to provide access to this data, so that innovators like you and others can use that to provide better tools for physicians and patients.
Yeah, very true. Let's keep our fingers crossed
Yes.
and hope so, right? I think it's moving in that direction of data
Yeah, I'm very
interoperability,
optimistic
right?
looking
So,
at the current leadership at CMS. I think
yeah.
they'll push it that way.
Yeah, that's so wonderful. So let's talk a little bit about where we see the future of healthcare, and let's touch a little bit on AI, how you got introduced to it, and where do you see it today, and where do you see it going in the future? And I know you talked a little bit about a lot about that in your book, actually. So.
Yeah. So, based on my experience, I've seen. So the way we did it with Crest Network was where this is very simple technology. It's nothing fancy.
Mhm.
And it's just simple. logistic regression, and those kinds of simple technologies that we used to be able to provide this kind of decision support. Um, as you can imagine, when we look at science in general, where does the medical science come from? The knowledge, right? Um, for us, what we did was we did a literature search to look for these um, applications or tools that are available in the literature.
Mm-hmm.
And then we applied those to a retrospective data set. And
Mm-hmm.
based on that, we saw that, okay, which ones work, which ones don't work in our population. Because some when somebody develops something somewhere, it doesn't mean that it can be applicable to your population. So we made sure that it worked in our population.
Mm-hmm.
And then we designed the application and we implemented it and tested it, did a clinical trial, and then based on that, based on those results, what we found is that our population is definitely different than the original population where that tool was developed. So
Mm-hmm.
we had to change the dials on the application, change the variables, um, change the weightage on the variables so that it is more applicable to our population. So what we just did was that we actually generated new knowledge by just applying this old knowledge and trying it out. And so that cycle has been completed where we did this trial and then we got the new knowledge and then we applied the new knowledge, and now it's going to keep running. Those cycles keep running, and so the quality of care and the predictability and everything improves with time.
Mm-hmm.
And that's when I started thinking about it. Oh, okay. So you can get this knowledge from the literature, or you can also generate that knowledge from your own population. Okay, so what are the tools you can use to generate that new knowledge from your own population? Well, machine learning has been great in that work. Whether it is supervised learning or unsupervised learning, you can create new knowledge from your own population. That was fascinating. And I've done some work with outside groups where we looked at sepsis and other conditions, and sure enough, you can generate new knowledge from your own population. And there have been examples of looking at length of stay, uh, readmission rates, and stuff like that, where you can predict those outcomes, um, just by studying the data.
Mm-hmm.
And so that got me thinking, oh, if we can study the data and come up with solutions, why not we implement that directly into patient care while we are doing these clinical trials? And so you generate new knowledge and then you implement that new knowledge and then you keep that cycle going. So where you're improving care and then implementing that knowledge and the cycle continues, and so it gets better and better each time. Now if you think about the traditional way of generating new knowledge is, somebody comes up with an idea, a a hypothesis, and then they pick a sample population and they do a study, and then they try to generalize that result to the general population. Well, the problem is that not all populations are the same. And when you actually implement that, a lot of these studies don't live up to their expectations. Some of them, they just fall through, and then there may be some negative results from it. So it's a very imperfect science where you're doing this in a small subset of the population, your study population, and then you're trying to implement that. Let's say somewhere in Netherlands somebody did a study and you want to implement that in California, it may or may not work.
Mm-hmm.
So why not develop that new knowledge from your own population and then implement it and then keep refining it. So that's the idea of how machine learning and artificial intelligence will be able to help improve the quality of care. And once we do that and automate a lot of the processes, you can actually decrease the workload on the physicians and the caretakers, because a lot of the stuff that we do can be automated. So it doesn't have to be a physician clicking these buttons to generate that data or to document
Absolutely. That's so fascinating. You talk about the new way that I think knowledge generation and research is going to change, right? Because earlier we were limited in, we had a different way of doing research where we would come up with a hypothesis, test it, and then it just got deployed. We
that.
didn't know what was the impact of it, but now with big data and real world evidence, we are able to
Yeah, exactly.
collect that information, derive insights from it, and then, like you said, being able to tweak the dials to what is right for our population, and that feedback loop continues to improve
Yeah,
the the recommendations and the predictions of what would help people, right?
yeah,
um, and I think I'm so glad you mentioned it, because that's actually exactly what we are doing at Helpsy,
good.
for yeah, for
I
symptom
know.
management and navigation for quality of life. Is we are able to, we took that knowledge which we thought people needed so much, that basic education
Yeah,
on how to handle their care, what to expect, and all of that. It started with that knowledge and the education of that. And then as we continue to serve people, now we have over 20,000 people that we have served,
wow.
400,000 symptoms. And it's continuing to grow. And that data started to give us insights into what's really happening with people, what's working, what's not working for them, what are the issues we can anticipate when. And the system has just gotten smarter over time, because now it's learning from that patient population what works, and it's also learning from so many clinicians in terms of
Yeah,
um, what it can do. And I think that makes it much more um, powerful. It allows us as a humanity to be able to develop smarter ways of taking care of ourselves. um,
exactly. Exactly.
yeah,
You're right on target there. And then it keeps getting better.
yeah.
It can only get better because as the system learns, as we learn the systems, and the quality of care improves, the outcomes improve, and hopefully the burden on physicians and nurses will decrease, and hopefully the quality of care for patients gets better. So
Yeah.
it's a win-win-win situation.
Right. So let's talk a little bit about that. I mean, that actually two thoughts going through my mind in terms of where to take the conversation.
Hmm.
Uh, um, but I'm trying to take one step back before we go one step forward towards the future. I'm trying to think about value-based care,
Sure.
because you talked about your work in emergency department, and we know we see and work with a lot of low-income population in the ED, right? Uh, so there is a huge need there. We are also seeing in the emergency department issues that could have been prevented if people had the right information, or there were other avenues for them that they knew about well and felt comfortable, they would have gone there, right? So we are seeing you talk about value based care in your book, and you saw that in real life from the very beginning of your career in terms of the impact um, of not having that streamlined care, and how not having value based care impacts everyone. And it's bad for the patient, for the clinician, for the administration, for the payer, for the pharma. Nobody wins, right, in this game. So as we are moving towards value based care, what are your thoughts on it? What are the problems you saw, and how do you see this value based care evolving from here?
Sure. um, one of the things that I noticed in my career at Kaiser Permanente, and I've been watching this closely, is that um, if you take, what are the preventable things? And if you take care of the prevention part, how will the outcomes change? And I've seen this in my own lifetime. Um, at Kaiser Permanente, and this is published data, and how they were able to drop the heart attack rates by 30%,
Mm-hmm.
the stroke rates by 50% compared to the community. And you would think about it and then say, oh, okay. So in the past, the idea was that, oh, if you had a heart attack, oh, okay, you got a heart attack, too bad, or bad luck. But now we know that, okay, if you have a genetic predisposition, if you're smoking, if you have diabetes, if you have high cholesterol, if you have hypertension, maybe your rate is pretty high. Okay, so genetic predisposition you cannot do anything about. So forget about that for now. But these other four, you can actually make a difference. How you can, you know, encourage the patient to stop smoking and why it is important. And how do you, control your sugar, your cholesterol, your blood pressure, right? So we think about these things as diseases, the diabetes, and so as a researcher, I don't think about it as a disease. I think about it as a risk factor.
Mm-hmm.
So every single thing is a risk factor. Well, if it is a risk factor, then you have to figure out where this risk starts and what are the other risk factors for this risk factor. Is obesity a risk factor, or lifestyle? Is the food we eat? And so that's number one. So everything I look at it as a risk factor. A risk factor for a bad outcome, which is it could be a stroke, it could be diabetic retinopathy, it could be heart attack, it could be peripheral vascular disease. All these things add up as risk factor for these bad things that happen in the end. Um, and that's why you see the preventive force, the U.S. Preventive Task Force. It changes the guidelines. It says, oh, more people at this lower level are also at risk.
Right.
It's more of a continuous. It's a continuum. The blood pressure, the cholesterol, the hemoglobin A1C. Those are all continuum. And so it's not, you have the disease or you don't have the disease. It's a risk factor, it's there, but how low is it? And how it grows to become a problem later on. So that's number one. So thinking about disease as risk factors. So if you start thinking in those terms, then you start to think, oh, how do I know if something is a risk factor? Well, I need enough data. And so again, now that we have almost 90-95% of the patients on EHRs, the data is there. It's already sitting there and waiting to be discovered. So, and then you can also get clues about, so that is prevention side, right? So you can use machine learning to figure out what the risk factors are and how they affect these outcomes, bad outcomes. You can also use machine learning to figure out what treatments work for these. How do we decrease those risk factors? What medicines work for your cholesterol for this kind of patient versus that. And if you think about the fee-for-service system, it was designed for these bad outcomes, which happen in the end, which is, oh, if we have a stroke, if you have a heart attack, if you have appendicitis, or whatever that condition may be, we are there to treat you. Um, and so fee-for-service or volume-based care is based on the notion that we will take care of you when you're sick.
Mm-hmm.
So that's a great thing. I mean, we need that kind of system where when you get sick, there's a place to go and they'll take care of you. But value-based care is based on how can we not get to be sick? How can we prevent you from getting sick? And so then you start to think about all these risk factors and how do you decrease the risk factors. So, so it's a total change in your thought process, change the way you think about disease. Is it a risk factor? And if it is a risk factor, how do you decrease your risk factor so that you don't have bad outcomes? And what we have found is that if you actually change the risk factors, decrease the risk factors, your outcomes are much better and you don't have so many heart attacks or strokes or end stage renal disease. All these outcomes can be brought down, and so the cost can be brought down. And so that's the main thesis behind why it's
Right.
cheaper and it's better, and also it's a different business model. Now, when you say value-based care, people have all these ideas about what CMS is doing. I'm not talking about that. I'm talking about the fundamental factors that go into talking about value-based care.
Right. The core paradigm of value-based care, and how it's a different way of thinking and working and designing the
Yeah,
entire system, right? Uh,
exactly.
so I can see, like you and I can see, how technology can play a huge part in that, right? In that paradigm shift of being able to identify the risk factors, work with people on those risk factors early on to be able to address those, so that they hopefully have lesser um, manifestation of those disease, or they're better controlled. um, that's one way we see the future of healthcare going, hopefully, right? Do you have any thoughts on where do you see the future of healthcare, either as it relates to value based care, or in general, where do you see it going from here,
So
uh,
one,
as it relates to technology, the role of technology in it?
yeah. So, and if you think about the business model, right? If you think about the value-based care business model and volume-based care, the difference is the healthcare companies make money in a value-based care. They make money if they keep the patient healthy. In the volume-based care, they make money if the patient is sick. So it's exactly the opposite of each other, right? So technology can help because of what we talked about, how to identify risk factors, how to manipulate the risk factors and make the risk lower, how to find treatments and how to diagnose things before they happen.
Hmm.
So all those things, the technology helps, the machines help. And if you think about a business model where, okay, technology can help value-based care very well. It can help volume-based care also, but you cannot say, oh, I'm going to use this technology to make sure that patients get sick. You cannot say that, right? And so it has less value in a fee-for-service system.
Hmm.
Whereas in a value-based care, it is the core. And so that's where most of the bang for the buck comes from. You by using technology to be able to identify these risk factors. So it's hard to do fee for service in using technology. Especially the machine learning part, because you can only use this technology to make the outcomes better.
Hmm.
The outcomes are basically the health of the patient.
Right, absolutely, absolutely. And I think technology can play a big part there, right? So let's playing the devil's advocate here. Is technology is like a knife. It can cut to make it easier for us and do good things, but if used incorrectly, it can also cause a lot of harm. And that's some of the concerns and risk and resistance that we are seeing in the use of technology, right? When it comes to data privacy and security, or being able to use that to determine if somebody is going to get some claims, or higher cost of care that they have to pay, it can have those risks too, as we are starting to look at technology being the one being a bigger part, playing a bigger part in our healthcare. What are your thoughts about that?
Um, any new intervention in healthcare has its risks. Let's say you propose a new medication, right? Of course, any new medicine will have its risk. There can be bad outcomes. Any new radiation treatment, any new surgery, any new procedure will have its risk, and so also technology definitely will have its risk. But that does not mean that we should not use it. We just have to study it and see. That's why whenever I work with, I only work in the research arena, because right now we don't know the full extent of what this can do. Yes, it is doing good things, but it can also, and that's why you need to put that research framework, and you're questioning every single action in there, and either you're justifying it or removing it. If you see a good outcome, then you're justifying it. If you see a bad outcome, then you're removing it. So it's like any other intervention. So I look at it as, let's say, if you're bringing a new drug to the market, yeah, of course, there will be side effects, there will be bad outcomes, but the question is it doing more good than bad? And compared to the previous drug, right? If you're doing a procedure, you compare it to the previous procedure. And so also technology needs to be compared to what the current practice is. Well, if you're missing 2% of the cases, and if the technology is helping you decrease that miss rate by cut it in half, well, using the technology is better then. And so you have to study every single intervention, every single application of that technology. So then only you can introduce it into practice.
Right. So your book's title. So and the problem we just talked about. Do you think can AI really be punished? Should companies be held liable? And how do you look at this system as it's coming up in terms of punishing the AI?
Well, actually, there's a correction there. It's
Okay.
not. It's not punishing the AI. It's punishing the machine.
Punishing the machine. Yes, you're
Okay.
right. Yeah.
So the title is "Punish the Machine: The Promise of Artificial Intelligence in Healthcare." Um, so if you look at the current system, the machines are there. When I say machines, I'm talking about information technology. Right now, it's EHRs basically, right? So what are EHRs doing? The EHR's job is to, number one, bill for care. And that's mostly for fee for service, right? When you do a procedure, you document it. And it's a great billing tool. It's also used to document what you did for medical legal purposes. And so that's why you see all these beautiful notes, doctor's notes, right? They talk about every risk and everything else. It's also used for uh, regulatory purposes, where you can say, oh yeah, I did this, I screened so many people for this, or I did this, I gave aspirin to so many people that are at risk for bad outcome. So you're documenting these things for billing purpose, for medical legal purpose, for regulatory purpose. That's it. That's the use of EHR. How does the EHR help improve the quality of care for the patient? How does the EHR help decrease the physician workload? It doesn't. So what it means is that you're punishing the doctor. You're punishing the doctor to do more work, to do more documentation, to do more clicks. So what I'm saying in this book is don't punish the doctor, punish the machine. The machine is not doing any work for the doctor. The doctor is working for the machine. The machine is not working for the doctor. So punish the machine, make the machine work harder, make the machine work smarter, make the machine provide help to the doctor. So that's so the way you do that is, helping with clinical decision support, decreasing the workload, decreasing the cognitive burden. And that's what I mean when I say punish the machine. And you're actually sparing the doctor and improving patient outcomes.
Yeah, yeah, making the machines more useful to the clinicians who are in need of that support and
Exactly.
leveraging instead of
And,
uh,
and and
yeah.
when you do that, when the machines become smart and they're helping, then the workload decreases. Then the doctors can do what they do best, which is interacting with the patient, showing compassion, showing empathy, um, understanding the patient's point of view, and creatively figuring out a solution to the patient's problem. Right now, we're not doing that as physicians. We are just clicking away.
Yes, we are. Lots and lots of clicks. That's the number one bane of for us as
Yeah,
healthcare professionals. So looking into the future, there is concern and there is hope when it comes to the impact of machines. Right, we touched on many of that. I think there is hope for improving efficiency and with making us more connected with people, and for all of us to have better outcomes. There is also the risk of if machines can do everything, will they take over our jobs? Can they have negative impacts? So, uh, as we wrap up our conversation, what would be your parting advice and vision for where we go with healthcare?
so there is um, so many nuggets that are hidden inside our data. There are cures waiting to be discovered. There are medicines that are waiting to be discovered using data. There are treatments. There are so many things that are hidden inside. When we figure those things out using machine learning and artificial intelligence, I think we as a human race will be much, much, much better, much healthier. Um, there'll be much less suffering. Okay, so that's number one reason why we need to do it. Um, and a lot of people ask me that question, oh, are doctors going to lose their jobs? Well, if you're doing, you know, um, if you're doing menial job, which is clicking, yes. If all that's all you do, yes, you will lose your job. But if you're doing a higher level of job, which is actually what doctors are trained to do, which is taking care of patients, understanding their problems, providing solutions, creating that environment of care, comfort, and support, no, you won't lose that job, because the machine cannot do that. So it will take away the grunt work, the scut work, where a machine can do much faster and much easier. So doctors need not get scared about it. They should get curious. They should start learning data science, understand how technology works to make things better. But they should not worry about it.
That's very, very nice, very positive, and inspiring message. So true. It is about how we become curious and how systems can help us to become better clinicians in what we are doing. They can automate
Exactly.
the work so we can be more present with our patients and we can handle the the granularity of the work
Yeah.
that is needed in this. So thank you so much for sharing your wisdom, Dr. Yuli. It's a wonderful book. I really enjoyed reading it. I hope
Thank you.
I hope all our readers check it out and read it. And thank you so much for your thoughts. I love the way you're able to go into the depth of things and share the reasons and the core principles behind improving healthcare. So I really appreciate that. Thank you for your time.
Thank
Um,
you very much, Sangeeta. Thank you for having me.
you're welcome. And thank you everyone for watching. And we will be back next week. New topic, new speakers. Stay tuned. Bye.
Bye bye.